One question I had is just in terms of the length of time that the Prevena is on the wound. One of the issues sometimes in our setting is this need to get patients out of the hospital. We'll often, have them go home the same day, sometimes no later than a day post-op. Clearly there's, a need for dressings like this. How do you handle that, getting the patient out of the hospital? They go home with this?
Yeah, all of my patients go home with this. There's two things you can do with the Prevena dressing. One is it's compatible with an inpatient vac device. So you can hook it directly up to an inpatient vac device. If you know somebody's going to be in the hospital for a while, maybe a really high risk periprosthetic fracture, something like that, where you want to have like that very large canister that the vac has, maybe they're going to be in the hospital for 3-4 days, then that's fine. We also have a small disposable pump that you can apply it, when you initially put it on. You can unhook them from the vac and apply it when they're ready to go home. And that is a small disposable pump, runs on AA batteries. Now we have another one that's called Prevena Plus that's also disposable. It's a little bit stronger, and that goes with our customizable version. But again, patients can go home. We recommend it stay on for about a week. And, ideally, I like to stay on as long as it can. Right now, we're indicated for 1 week. Our pumps, actually, our Prevena Plus pumps, we have new versions that will last 2 weeks recently. I'm not sure if those are available yet in Canada, but we don't yet have regulatory approval for the dressings to stay on for 2 weeks. So in general, now I leave them on for a week, and either I have them come back and, if it works out with my clinic, typically it's one of our, medical assistants or PAs that will remove it. If a patient cannot get back on that exact, after the week, once the pump will automatically shut down. The software has it shut down on day 7. And so they can leave it on it's similar to having like a Tegaderm, and there's some silver, there's some ionic silver in the part that touches the patient's skin. So if they need to be at home for another day or two, that's fine, and then they can remove it. And I have on occasion had patients, they can't get in, I just tell them to remove it, because it's simply, the drape part of it is simply Tegaderm. It's very easy for a patient to just remove it. But that the intention is that I like them to come back and have a healthcare provider see.
I was just going to say, and do they need any special teaching in that first week, or is it pretty straightforward? They can be taught before they go, and they kind of
there's nothing for them to do. They don't need to do anything. They don't need to change it. They don't need to touch it. Now, if something goes wrong, if there's a leak or an alarm, then that is, they would generally call the office. And what I generally tell them is, okay, if it's not something where obviously there's a lift and they can fix it, just turn it off. Because again, in and of itself, it has an antimicrobial layer that touches the skin. It's a sterile dressing at the very least. But I really can't remember the last time I've had a problem with it. We're sort of on version 5 of this, and it works quite well. I've been very pleased with it.
And for the second week, staples are often removed in arthroplasty cases at 14 days. For the second 7 days, is the wound left open to the air, or is it covered with a different dressing? Or
So generally speaking, when you remove it after 1 week, as I showed in some of those pictures, the incisions tend to look like a 3-week-old incision. And so most of the time, open to air. If in the unusual circumstance where maybe there's, a small, separation, or, maybe you see a small amount of drainage, or again, that's very unusual, then, you might want to apply some sort of cover dressing. But that's extremely rare to need to do that.
In the chat, we have a comment that says, in Canada, we have Prevena that can stay on for 7 or 14 days, and patients can be discharged the same day, it says here.
All right. Thank you.
So there you go.
So you do have the 14-day pump there.
It sounds like it. Are there any barriers to the use of it? So like, it seems like it's something that we should be putting on a lot of incisions. Are there any reasons why it shouldn't be applied? Like, would there be a contraindication?
So as I mentioned, there's ionic silver in the part that touches the skin. So in a rare, I haven't seen one, but there's some people may have a silver allergy. That would be, or if someone has a hypersensitivity to the, it's Tegaderm drape for the peel in place ones. For the customizable version, it's our typical vac drape. So if someone has a, hypersensitivity to adhesives or something like that, again, it's very rare to have a problem with it. I think that the decision on whether or not to use it, I mean, look, if it costs nothing, I would, you'd want to use it on every patient, because again, because of that. Okay, there's the one benefit about reducing complications, and so there's sort of a cost benefit there. You can say, okay, well, how many complications that I'm preventing, does it make it economically worth it to use it? So there's that way of looking at it, but it does that other benefit of reduced swelling, looking at the incision and feeling like it's further along. We believe maybe that will lead to, we believe maybe that would lead to improved function. If you have less swelling around your knee, are you going to be able to bend more, that sort of thing. So I think that it becomes a cost benefit analysis. And so today, we still are really recommending that this be used in higher risk patients, because we have solid evidence that it reduces complications in higher risk patients. And, you can look to the literature to see which one of those higher risk, certainly revisions that have a comorbidity, primaries that have certain comorbidities. And then, we need to provide evidence for these other observed benefits like reduced swelling, et cetera.
I see a very lengthy comment from CJ Foote around open tibia fractures. CJ, I wonder if you might ask a question based on that comment.
Well, I see that question there, and I would say that first of all, the Wolf trial, okay, my understanding of that is that was the use of negative pressure wound therapy in an open wound, so it's separate from what we're talking about here, and it's in open wounds, and it's looking at it was a trial on that. And I really had major issues with it. I guess it's quite a long discussion there, but my belief is that's a separate thing. But just very briefly, the use of VAC in open fractures in particular, the advantage of that for me as a plastic surgeon, and so basically a patient comes in with an open fracture, you go to the OR, you do a debridement, you wash them out, you apply VAC. And for me as a plastic surgeon, when I've been called in because there's a need for soft tissue closure, what I find is that when you use VAC, as long as it's applied early enough, you save some of the domain. You don't have that retraction, that splaying open of the tissues that you get when you just pack the wound. And so sometimes the flap that is needed is smaller. Sometimes you can use a local flap as opposed to a free tissue transfer. And the overall morbidity is less. Plus, I think there's advantages. Typically you're not using it for more than a week in that circumstance. So it's not a lot of days. And so to do a comparison, it's a very short window of using it. But I think a lot of the benefit also is to the patient that doesn't have to have frequent, gauze dressing changes, sometimes 2-3 times a day. To the staff, you're not getting drainage all over the bed and everything because it's very nicely controlled. So I think there are other benefits, but I believe it's the morbidity of the magnitude of the reconstruction that's needed in those particular patients. The other thing is I would say is that we now at University of Maryland use VeriFlow therapy, which is VAC with the installation of a fluid, and typically in an open fracture it's an antimicrobial fluid. And I believe that makes that whole discussion almost like of historical significance, Because clearly, if you have an open fracture, why not clean it out? You can use Veriflow and you can irrigate that wound in an automated way without taking down the dressing like 20 times in a 3-day period if you just use the default settings. You can do it every hour if you want. And I think in those situations, that might even allow you to not necessarily, you might even be able to wait a few days longer to do it. The logistical benefit of just keeping the wound very clean. So I think that it's a very interesting comment. And I would love to discuss that at greater depth at some point. But it's a little bit off topic because that's more about open wounds, whereas Prevena, I was talking about using it in closed incisions. But I'm very glad to see this comment.
I mean, I'm just getting back to the talk. There's no question that in arthroplasty, there's definitely a high risk patient population. And do you think it's more about doing a revision versus a primary, or is it more about just the high risk patient? I mean, I sometimes have patients, that a BMI of 50 that are diabetic, and I'm doing a primary total knee. And I'm much more concerned about that patient than I would be, doing a revision, even with some of the other risk factors that were listed. I mean, I think in many instances, it's the risk of a specific patient, irrespective of what it is that they're getting from the surgeon.
No, I totally agree with you, and I think that our challenge when we designed that multi-center randomized controlled trial was that we wanted to find something that would be consistent to study. And we knew that revision, basically you have to pick a subset of patients that have a high enough complication rate that you'll be able to demonstrate a statistically significant reduction without having to do a 10,000 patient study. And I think that we knew already that revisions, because of that Cleveland Clinic study by Higuera, we knew already that this was a very, we felt very confident that we could achieve that result, and we just wanted to prove it. But basically a revision, and again, those are revisions that had at least one comorbidity, but a revision is one example of a high-risk patient. But I think certainly the obese primary is another high-risk patient, and that's why I showed that series from Toledo, Ohio, that was essentially an obese population, and we were able to demonstrate a reduction there in complications.
There's another question here. Can we cut and refashion the sponge of the Prevena?
So you can cut. There's one version called Prevena customizable, and that is the one that's 90 centimeters long. So that's intended to be cut and placed together, and I've seen people place it almost in parallel or wrap it around. The other versions, the Prevena, there's a 20 centimeter and there's a 13 centimeter peel in place, and there's actually a 30 centimeter single peel in place also. Those really are best not to be cut because it's just sometimes hard to get a seal if you cut them, because they're just the way it's manufactured. It takes a little bit of an effort. You can do it. I've done it, but it's suboptimal. So, but the customizable one absolutely can be cut and refashioned. So if you want to do that, that's the one to do it with.
And then another question, how often do you recommend changing the dressing? In other words, what is the limit of effective single use?
So our labeling for the dressing itself in the US is 7 days. We have 14 days in other countries. And according to the earlier, it's in Canada is one. So there are surgeons that leave it on for 14 days. We have some surgeons that want to leave it on for 21 days. But you have to make sure, if you want to leave it on for 14 days, you have to make sure that you have the pump that will last 14 days, because some of the pumps only last 7. So it'll say on the pump whether or not it lasts 7 or 14. And you just need to make sure of that. It'll say on the box. But remember earlier I said that you can also hook the Prevena to an inpatient vac. So if you have a patient that's in the hospital for a few days, let's say they're in the hospital for 4 days, you can put them on the inpatient vac while they're in the hospital. You can then take them off of that and hook them up to the disposable pump, and then you get extra days doing it that way. As a matter of fact, the publication out of Columbia University on arthroplasty is one of the ones that I showed you. The average length of therapy was 9 days, and that's because in general these were the revision arthroplasties. He would keep him in the hospital for 2-3 days, and then he would hook them up to the disposable Prevena pump when they went home, and so he would get a full 9 days of therapy. On average, it was 9 days, somewhere a little bit longer than that.
And in terms of the wound closure, I mean, many of us will use, a subcuticular closure. Some of us will use staples. Some of us use a combination of subcuticular and staples. Is there a preferred way to close the wound underneath this dressing, or can you pretty much do whatever it is that you would normally do?
You can do whatever you would normally do. There's really not, in the Promises study, we allowed any of those things that you said: staples, sutures, subcuticular. The one thing that we didn't allow in the study is the use of glue, skin glues. The reason for that was simply because if you put let's say you use something like Dermabond, you put glue on the surface of the skin, and then you apply the Prevena. If the glue is not dry, you might glue the Prevena gets glued to the skin. Now the Dermabond will flake off eventually, but sometimes that takes a little bit longer than what you would like. And so then if you went to pull the Prevena off, you might end up like denuding the skin a little bit as you peel it off. Some people do use it with glue, but you just have to make sure the glue is totally dried. I don't see a benefit to using glue with it. I think the negative of glue is that it kind of seals it, and I like the ability, if there is going to be drainage, I like the ability of that drainage to come through and get taken away. And typically, if there is drainage, it's really only for the first 12 hours at most. And then just because of that opposition, you get really quick epithelialization. The one exception to that is hip. I've seen some patients that when they first get up after having a hip operation and bend, there's like a little rush of fluid that comes out whatever that time point is. And so we have had a few circumstances where we've gotten requests for, you would ask me, is there anything that the patient has to do? Most of the time, there's nothing that they have to do. But for some reason, in some hip arthroplasty patients, there have been requests for a second canister because they get filled with fluid. And so that's easy. You just take it out and put the second one in. We do have separate extra canisters. It's uncommon. It's usually not needed. I suspect that the surgeons that required them, it's maybe because they just did maybe a looser type of closure. Maybe they wanted to do a looser type of closure to allow drainage. I don't know, but it's not something that's common.
I was just going to ask, is that an issue if you're seeing too much drainage? So is there a point at which you then become concerned with, excess drainage, or is that not?
So as I said, typically you don't see that. So typically, because you get such rapid, good approximation, there's a sealing. There's almost, the edges epithelialize very rapidly when you use Prevena within the first 24 hours. That's based on our animal studies. That's what I've seen. But I think that, if there is drainage, I think that's probably a good thing because you want to remove it. The circumstances where where I have seen patients with drainage in orthopedic cases, a periprosthetic fracture on someone on blood thinners that just had like big hematoma. I recall a case at University of Maryland where they hooked it up to the regular vac and it was just filling. It was just filling, a large canister. But ultimately it slowed down and stopped. And it was just really during the first, 2 days or so, two into the third day, and then it stopped. I think it's good to know that you're having drainage, but I don't think that's a reason to stop the therapy because I believe you're helping the situation by removing that drainage.
Right. Okay. Well, I think we're at 9 o'clock. Abby, are we at the end of the session? If we are, again, I'd like to thank you, Ron, for an outstanding talk. And I think we've had a really wonderful discussion, tons of questions, and we went the full hour, and I think we probably could have kept going. So much appreciated.